It's time for Wave 3 Listens Live, taking your calls to hear what you have to say on Louisville's only live local TV talk show and hitting the streets to be live on location in your community. All hosted by Cindy Sullivan. Now, Norton Healthcare presents Wave 3 Listens, Healthy Living Live, brought to you with the support of Louisville Athletic Club.
And welcome to Healthy Living Live. I am filling in for Cindy Sullivan. Happy to do so. We are at the LAC located on Westport Road, and the energy is unbelievable in this building. I'll tell you what, people are working out. We're getting after it. We've got lots of good news for you. And I'd like to introduce you to our co-hosts. You know who they are, Bob and Caroline Scott here at the Louisville Athletic Club. And guys, I've got to tell you, I love the energy. This is the time to do it. It's a little nasty outside, but it's nice and toasty in here.
Yeah, everybody knows that they need to come in here right now because they don't need to be outside.
The weather is on its way from what we've been hearing. I know that all the weather updates are saying, I guess, 3 to 6 inches. So what better place to be working out than to actually come in LAC right now and get a quick workout in before the weather hits.
And give us the play-by-play. There is so much energy in this room, and there's a reason. We've got a class over here, Caroline. What kind of class is going on over here?
I think we've got a step class, maybe a combo step weights. This class is great. It's always full. Alicia, she's our group fitness director. She's awesome. So.
Alrighty. And of course, lots of action back here. People using the weights on the cardio machines over here on this side. And there's a lot of specials to be had here right now at the Louisville Athletic Club, Bob.
Yeah, now's the time to join. If you've ever thought about joining a club, we encourage you to come out right now because we are running some phenomenal specials.
Alrighty. Well, we encourage you to come on out to a LAC near you. Real quickly though, Caroline, your locations?
We have obviously Westport Road, which we are here, and Taylorsville Road in J-Town, and Clarksville, Indiana on the Lewis and Clark Parkway.
Alrighty. Come on out today. It may be the day to start your new regime. And now let's talk to our friends from Norton Healthcare. In fact, we're talking to the doctor who is from Norton Orthopedic Center, and this is Dr. Khalily. Dr. Khalily, welcome to the show.
Thanks. Glad to be here.
You look like you know your way around a gym, my man.
Just skinny.
He is fit. Don't let him fool you. All right. Dr. Khalily, what is exciting right now in your world when we're talking about orthopedics, and in particular knee and hip replacement? We talked a little bit, and what I found exciting is the fact that a lot of my friends were feeling a little pain in their hips, a little pain in their knees before they would hesitate because they said, I can't take the downtime, John. It's exciting to be able to say that downtime, don't get me wrong, you're going to get a little of it, but doesn't exist like it used to.
Well, we've made a lot of progress in the world of knee and hip replacement just in the last few years, and we continue to make that sort of progress. And so what I do is all about patients' quality of life. And so what we want to do is get you back to an active and healthy lifestyle as quickly as possible. And so with our accelerated rehab program, what we found is that we can do that. Less downtime, less time in the hospital, quicker rehab, and able to get back to what you need to do quicker.
Okay. For those who are watching, doctor, if you would, what are some of the symptoms? Obviously, if you're feeling pain, but is it persistent pain? What do you exactly look for when you're thinking this might be a candidate to have a knee or hip replacement?
Yeah, that's a great question, and I encourage anybody that has persistent pain in their knee or hip for more than a few days that doesn't respond to over-the-counter medicines to see your family doctor or your orthopedist. With hip pain, most folks think their hip is sort of their lower back or their butt, but really your hip is your groin. So if you feel pain in your groin, a lot of times that's hip pain. If you feel pain in your knees, obviously you know where your knees are, and we've all had pain here and there. But if it's persistent and it doesn't go away with Tylenol or Advil, you probably ought to get it looked at. Some of the signs of arthritic pain are what we call startup pain. A lot of folks will come to me and they'll say, you know, when I sit down for a while, then I get up, it takes me a few minutes to get going. Then when I get going, I'm okay, but after I walk for a while, then it'll start to hurt again. So that's an arthritic type pain. Stiffness, loss of range of motion, and pretty much more bad days than good.
Okay, interesting. Now let's talk about the surgery itself. Is it more, actually less invasive than it used to be? I see all these nasty scars from people who had surgery as little as 5-10 years ago. Right. Different procedure now, Doc, right?
Well, what we're talking about here is knee or hip replacement, and obviously when you come and see me, that's not the first thing we talk about. There are a lot of things that we need to do and patients need to do to try to maintain the health of their joints and try to delay surgery. Surgery is a great option, but it ought to be the last option. But when we talk about knee and hip replacement, it sounds a little bit worse than it is. We don't just chop your knee out and put a big hinge in there. What we do is we resurface the worn out, articular surface of the joints, the hard, smooth surface that gets worn out with arthritis. And so you don't have a whole new joint, you just have a resurfaced joint. What we do that's minimally invasive or less invasive is that we don't cut the muscles, we don't cut the tendons, and we respect the normal anatomy so that there's less damage when we're doing what we're doing. That way you get better quicker.
No reason to implode the entire building, right? If you can just work around it and keep the structure.
That's exactly right. So when we talk about less invasive surgery, what I talk about is not a smaller incision, and it does end up being a smaller incision sometimes. And the way I do surgery, we don't even use any stitches. It's all under the skin and with glue, so there's no staples or stitches generally. But what happens under the skin is what's important. And the way that we resurface the joint is sensitive to your anatomy and your muscles and your tendons. And I tell my patients, when I do a knee replacement, I don't cut any muscle, don't cut any tendons. All we do is resurface the joint.
Well, I've got to tell you, Dr. Khalily, I was completely amazed at the time frame. If you could be a little bit more specific with folks who are thinking about a knee or hip replacement, what kind of time frame are we talking about before you're up and going again? Because as you know, we're all busy these days.
That's right. The goal of joint replacement obviously is to relieve pain. And so what we want to do is we want to relieve that pain quickly and get you back to your life quickly. So with this accelerated rehab program, which is a combination of surgical technique, new surgical implants, pre and post-operative pain control, and rehabilitation, we can get you up and going quicker. So when I do a knee or hip replacement, the patients are up walking the day of surgery.
Whoa.
At first they'll need to use a walker. Usually folks use a walker for a few days, then a cane maybe for a couple of weeks, but typically after about a month, you're off all walking aids. We looked at our patients, and of the patients that go home, now some of patients need to go to rehab just because of their social situation. If there's no one at home to help take care of them, they may need to go to rehab. But the vast majority of patients go home, and of those patients that go home, half of our patients go home the next day. So it's a one-night stay in the hospital. Approximately the other half of the patients go home the day after that.
Oh, that's
so
incredible.
1 night or 2 nights in the hospital.
Wow, that is nothing but good news for those of us who may be looking at knee or hip replacements. And if I'm not mistaken, Doc, correct me if I'm wrong, but in the past it could be as much, you could be in the hospital and not just rehab. I'm talking in the hospital for a couple of weeks, 2 or 3 weeks.
Oh sure, we don't even have to go back that far where folks would stay in the hospital a week or two. They weren't able to walk at first, they'd be non-weight bearing on their extremity, they couldn't drive for 2 or 3 months. Rehabilitation would take 2 or 3 months. And so the goal of what we're doing is to cut down that time frame. I mean, as you alluded to, clearly there's some downtime. It's still a big surgery, but we just get you better, quicker, and it's a combination of efforts of all of the team that is involved with this joint replacement. The other thing that's really important is that we try to get the family involved in the patient's pre- and post-operative rehabilitation. So we designate someone as a coach, and this is the person that's going to help with the rehab. This is the person that's going to help with the meals and so forth when you go home. Because you're going to be ready to go home, but you're not going to be just on your own right at first.
Right.
And so all of these things help you get better quicker.
Well, if you have any questions, perhaps you have someone in your family, maybe it's you, that may need hip or knee replacement. You have a seminar coming up. We're going to put the information up on the screen. You can meet Dr. Cyna Khalily live. Tell them all about it, Doc.
Yeah, so we're having a seminar, and it's, if I'm not mistaken, February 28th. It'll be at Norton Healthcare Pavilion, which is downtown. That's the old Methodist Hospital, and it's at 6 o'clock. And I will do a brief presentation, a slideshow, and then we can have a Q&A, and we can talk about really whatever folks want to talk about, but knee and hip replacement in particular.
All righty. Bob and Caroline Scott, Dr. Khalily, we're all here. Healthy Living Live. We'll be right back on Wave 3 Listens Live.
Is working for you.
And welcome back to Healthy Living Live. I have our friends from Norton Healthcare with us, and of course our host from the Louisville Athletic Club. And a little extra bonus if you call in today. Bob, Caroline, what are we going to do?
Absolutely. Anybody that calls in the show today, we're going to give them a free 1-week pass. It'll be good at any of our area locations, so no excuse not to call.
All right. And today's the day to do it.
That's right, today.
All right, Dr. Khalily, we had a call, and it was funny because the news is almost so good it's hard to believe. Caller called in and said, I think the doctor said that you could be home the next day with a knee replacement. They're not sure. I think they believe it, but they want to make sure that is exactly what you said.
That's what I said.
All right, that's what I want to hear. And the reason for that is?
And again, the thing is, we don't kick people out the next day.
We're not going to hobble
yeah,
out.
right. But again, with this system, of the patients that go home, some people need to go to rehab, but the majority of patients go home. half of those patients go home the following day. I had a patient that I did surgery on yesterday. They went home today.
And that's typical.
And that's typical with what we're doing.
All right.
And so, if you need to stay another day for whatever reason, you can, and then you can go home the next day. But typically, it's 1 or 2 nights in the hospital, and that's it. And again, it's not that we want to kick folks out of the hospital, but there's no place like home. You know, the food of the hospital may be okay, but it's not as good at home.
It's not as good as Grandma's cooking.
That's
Come on
right.
now.
It's not as good as home. The bed's not as comfortable as at home. Everything's better at home.
I tell the kids, everything, the dog. Come on.
I tell people, there's no place that's better to get sick than the hospital. You need to get home quick, and you need to get back to your life quickly, and that's the goal.
All righty, there's your goal, and there's your answer. We've got other calls on the line. Let's talk to Frank, who is patiently waiting. Frank, you've got the doctor. Go ahead.
How you doing, doctor?
I'm good. How are you?
Fine. My question is, I had knee replacement in 2005, but I still have a lot of trouble with my new knee, as you might say. You know, it feels like I still have trouble, like it feels like an old knee. Do you do anything for that?
Well, yeah, it's important that folks understand there's no guarantees. Knee and hip replacement are an incredibly successful surgery. They relieve pain in the vast majority of patients, and most people, greater than 90% of patients, are happy they've had the surgery and have a good, long-term functioning, pain-free joint. But there are some patients that will have pain, and there's a lot of reasons that you could have pain after joint replacement. Sometimes there's just no reason. Sometimes, you know, you've had a surgery, it's just going to hurt. Other times there are reasons. Now, in your case, Frank, I'm not really sure what's going on, but you ought to follow up with your surgeon or a orthopedic surgeon and be evaluated to see if there's something that can be done about your continued pain after surgery, because obviously the goal is not for you to continue to have pain.
All right. Frank, thank you so much for your call, and we'll grab another one here. Susan's on the line. Susan, you have Dr. Khalily with Norton Healthcare. Go ahead.
Well, I'm actually a patient of Dr. Khalily's. I had my first knee done 2 years ago, and another knee replacement 2 months ago. And I can attest to the fact that I was home the next day. Everything's gone well. I no longer use a cane. I don't even take a Tylenol for pain anymore. It's I'm riding a bicycle, I'm walking, and those are things I could not do before. So he's good, and it does work. It's great.
What an endorsement, Doc. What an endorsement.
I'll send you your check later, Susan.
Susan, thank you very much for your call. And something else I think is worth mentioning. Obviously, we have commercial breaks here, and you and I were talking a little bit. And you said the surgery is actually goes so well that it's not uncommon for someone to have one knee replaced and go, look, I'm going to go ahead and have the other one done. That wasn't so bad.
Yeah, that's true. I mean, a big majority of my business is repeat business, and I have a lot of patients like Susan that have had one knee done and the other knee done, maybe a hip done and the other hip done. And so I tell folks that one of two things will happen. If you've got arthritis in one knee or both knees or both hips, if we do one of your knees or one of your hips, one of two things are going to happen. Either you're going to come back and say, you know what, my other knee or hip doesn't hurt that much anymore because I'm walking more normally now, and so I can put this off. But just as often, folks come in 3 weeks after surgery and say, I feel so great, I didn't realize how bad my other knee was, let's hurry up and schedule the other one. And we can do that also.
All right, good. Excellent. All right, we have Bob on the line. He has a question for the doctor. Go ahead, Bob.
Yes, I had my knees x-rayed, and they tell me I've got bone spur. And I was wondering if there's anything you can do for that without major surgery.
Okay, well, it sort of depends without having seen the x-rays, but we can talk a little bit about what arthritis does to your joints. What happens with arthritis is the smooth surface of the joint gets worn out, and under that smooth surface is bone. And so then when you start to walk, the bone starts to rub on the bone, and that causes pain. And I tell folks, bone is pretty dumb. All bone knows how to do is make more bone. You start to stimulate the bone, it's going to try to heal, and that's what forms bone spurs. So if you have bone spurs, the bone spurs themselves may be a problem, but it's a symptom of the arthritis. So just getting rid of bone spurs is not necessarily the answer. It's dealing with whatever the source of the bone spurs is, which typically is arthritis. So again, without seeing your x-rays, I don't know, but if you got bone spurs, you've got arthritis. And so that's what we got to deal with.
All right. Once again, Healthy Living Live, we're here at the LAC. And Doc, we have a few visual aids.
Okay.
And if you would, show us exactly what we're looking at here and what your surgery involves.
Okay, so what I I'd like to emphasize to people, again, is that we don't just chop your knee out and put a big old hinge in there. The knee is a very complicated joint. There's ligaments, there are tendons, there are muscles, and so this is sort of what your knee looks like, and you got your thigh bone and your shin bone, and it moves this way, and there are ligaments and tendons. And so what happens with arthritis is this surface here that's smooth gets worn out. And when that happens, these meniscus, which is a soft cartilage, gets torn. And then these start to rub together and it hurts. And like our last caller was mentioning, you get bone spurs, and the bone spurs hurt also. So what we do with joint replacement, it's more like a joint resurfacing. We call it total joint replacement, but that just means we replace both sides of the joint. So this is a model of a knee replacement. All the white stuff here is your own ligaments, bones, tendons, kneecap. The only part we replace is this end part here. So we shave off the part of the bone, the cartilage that's been worn off, and simply resurface it with a metal part. Same thing on the tibia bone. We resurface this part that's worn out, and then there's a piece of plastic in between that acts as the cartilage. And so it looks like a knee, shaped like a knee, moves like a knee, all your ligaments and tendons are there, your kneecap is there, but the bone's not rubbing anymore. Another common question that folks ask all the time is this an off-the-shelf knee? Is it one size fits all? Is it a man's knee? Is it a woman's knee?
Sure.
Every knee we do is customized somehow. It's sort of like going to the tire store. There's a whole bunch of tires on the wall. Whatever size tire fits on your car, that's the size we use. So there are a lot of precise measurements and so forth, but your knee will be customized to you. I bet your knee is not the same as mine.
Sure.
And so everybody gets basically a customized knee.
All righty. So rotate those tires every once in a while, right?
That's right. That's right.
All right. Dr. Khalily is with us. We're Healthy Living Live. We're live at the LAC. If you have a question, give us a buzz. We appreciate you watching. We'll be right back. Welcome back. Healthy Living Live. John Ramsey along with Dr. Khalily from Norton Healthcare. We're talking about orthopedics today. We're talking about knee and hip replacements, and we welcome your calls as always. Velma is on the line. She's up first. Velma, first of all, you have a free membership, a week membership to the LAC, and you've got Dr. Khalily. Go ahead.
I have been told by a previous doctor that I have got bone rubbing bone. I know my knees are bad. I hear tell there is a new gel substance out that can cushion that and maybe not to have the surgery. What's his opinion on this?
Okay, well, hi Velma. Bone rubbing on bone, that is arthritis. That's what arthritis is. The gel stuff that you're talking about is a good thing to try. Now, I want to make clear, it doesn't really cushion and it doesn't build back cartilage or anything like that, but it is a way to help relieve pain. And so it's worth a try. You got nothing to lose, and that's always something that we try first before we proceed with surgery. So again, if someone's telling you got bone on bone, that means you've got arthritis. And a shot like that is worth a try.
All righty. And also recommend that you go to the seminar. Again, Doc, they can come to a seminar. You're going to show it from start to finish. And I think it's important to emphasize, as you alluded to there, that it is about the individual. Everything is personalized, from the knee to the rehab, etc.
Right. And with Norton Orthopedic Care, we have a series of seminars, and every month or two we'll have a seminar on a different subject. And in February, I'm doing a seminar. It's February 28th, downtown at Norton Hospital at the Norton Pavilion. I think it starts at 6 o'clock. I don't know, maybe there'll be snacks, but we'll do a little presentation, and then again, the most important thing I think for patients or prospective patients is they like to get their questions answered, and so I'll be available to talk to you about your options.
All right, Dr. Khalily, we've got another call. I've always wanted to do this, and finally I have a caller with the right name. Hey, yo, Mick. Hey, yo, Mickey.
Yeah,
hey, Mickey,
buddy.
welcome to the show. Hey, Mickey, how are you?
Oh, pretty good, sir. How about y'all?
We're doing great. Go ahead.
Yeah, the question is, my mother, she's 87 years old, and she gets up and she says she got something catching in her hip, or by being our age, would it hurt if she was to have something done for that?
That's a good question. You know, the age groups that we're dealing with here is very interesting. And you should know that traditionally, joint replacement was for an older population. older folks are the ones that get arthritis. And so that's who we would do joint replacements on, folks like your mom. And so it wouldn't harm her to go see someone, get some x-rays, see what it is that's clicking in her hips. Based on her age, more than likely she's got arthritis. But on the other side of the token, there is a younger, more active generation that's not willing to sit still. And so we are seeing more and more younger and younger patients that have really terrible arthritis in their knees and hips, and we are pushing that envelope to a younger population as well. So, it really, age is a relative indication or contraindication. What's important is your function and the degree of arthritis and disability you have. So your mom is certainly a candidate for a joint replacement if it ends up that that's what her problem is.
And I think this is great news for the younger generation in that if you're a weekend warrior and you have a hip or knee injury, don't give it up. Sometimes, okay, I'm getting too old, I have to hang it up, I'm 40 years old, whatever. You're saying, hey, we can fix that. We can give you a new knee and you can get out there and still get after it.
Well, we talked about that a little bit at the break. And as you get older and your body changes, you have to adjust sort of what you do. You've got to modify your routine. And I always tell patients, I encourage running because running is good for my business. High-impact sports are tough on your joints, but running is easy and quick. But
they're addictive.
Right, absolutely. So I never tell folks to stop running because it's not going to happen. But it's important that you stay active. However you need to. Swimming, biking, elliptical, a gym such as LAC, running, whatever it is, it's very important that your entire life you stay active in one way or another. And if you get to the point where you just can't do it anymore because of hip or knee arthritis, that's when we can do something about it.
All right. Judy's on the phone. She is certainly active. Judy, go ahead. You have Dr. Khalily.
Yes. My husband needs a knee, and he is, the doctors where we live won't touch him because they say he's overweight and he's a diabetic. Is that a problem?
Well, medical comorbidities certainly are potentially a problem. It's important that we fix you and get you back to a healthy lifestyle, but again, I tell people it's not worth killing you for it. So it depends what the medical doctors and the heart doctors say. If he is able to have surgery, if someone's allowed to have surgery, then they could potentially have surgery. Now, obesity is a problem. Diabetes is a problem. Again, these are relative contraindications. They're not absolute contraindications. If you're really obese and really overweight, that's part of the problem. That's why you got arthritis, probably. But it also can really affect your rehab and your healing, just as diabetes does. So I wouldn't say that if you're overweight and diabetic, you can't have a joint replacement. I would have no business in that case. So it just sort of depends if someone is medically stable and able to have surgery.
All right. Judy, thank you for your call. We're now talking to Bill. We are live at the LAC. Go ahead, Bill.
Yes. Thank you for taking my call. Talking some more about obese patients, I'm wondering how you do it differently with obese patients and what your success rate is with the patients who are obese.
Well, that's a good question. There's nothing really different in the surgical technique with an obese patient versus a patient that's not obese, except, bigger knee, bigger cut, it's just a little bit more dissection. The thing that concerns me with the patient that's extremely overweight is that there's a lot of adipose tissue between the skin and the muscle, and sometimes that stuff doesn't heal very well. And that's just soft tissue, that's not the bone. And then it's a lot more pressure on the joint even after the surgery. And so obesity, again, is a problem, but it doesn't mean you can't have surgery. Sometimes it does, but not always. So it just depends on the individual situation.
All righty, Bill, thank you very much. The seminar again, Doc, tell them.
Okay.
February 28th, let's sell that baby.
We're calling this Healing at Home. This is part of the Norton Orthopedic Care seminar series. The next one is February 28th at the Norton Pavilion downtown. That's the old Methodist Hospital, and it's at 6 o'clock, and I'll be there. We'll do a little presentation, and I'll be available to answer any questions.
All righty. Dr. Khalily, thank you so much. Healthy Living Live, we're coming to you from the LAC, and we'll be right back.